Welcome back to the channel. This is Pulse Education. My name is John Carrico. Glad to have you back, or glad to have you for the first time to Pulse Education and our channel, where we are pursuing lifelong sustainable education. And right now we are exploring lots of topics of cardiology. Hopefully you've been enjoying the content, or if this is your first time coming to the channel, we really hope that you enjoy the content and learn a lot. As always, please leave us comments if you have any comments or if there's any topics that you're hoping that we'll cover in the future. Leave us some comments and we'll gladly try to get into those, dive into those, and help us all learn, in this case, cardiology. All right, so this week's topic that we're talking about is a really important one. It seems basic at first, but it's really important in terms of interpreting 12 leads and really kind of identifying what we're talking about, what the heart is actually doing. And in this case, what we're talking about this week is the QRS complex, okay? So the QRS complex, it represents the depolarization of the ventricles. So the activation of the ventricles, the squeezing, if you will, when the ventricles are actually doing what they're supposed to be doing. This is the electrical interpretation of the ventricles actually squeezing, is our QRS complex, that depolarization, okay? So why is it that we are spending this week's episode talking about the QRS complex? It may seem pretty basic at first that, okay, it represents the ventricles depolarizing. Well, we know that while we commonly refer to as the QRS complex as that, one that has a Q wave, an R wave, and an S wave, we also know that a lot of times we don't have QRS complexes that actually have all three parts. In fact, QRS complexes, while they all represent the same thing in terms of the ventricles firing off, depolarizing, they can all look very different from each other. And that's information that we need to interpret. Why do they look different? What does each of those morphologies mean? What is it telling us in terms of our patient and how we're interpreting the 12 lead? And that's what we're going to kind of explore a little bit here today and have a little bit better understanding of. And that's where our hope is with us. So we'll start just by talking about just the normal QRS complex and the different parts of the QRS complex and making sure that we're identifying them. And then we'll explore the different morphologies that we may see. So in review, remember that the Q wave itself, the Q wave is the first negative complex after the P wave, or in some cases where the P wave should be. That first negative deflection, immediately after that, that will be a Q wave. And we'll talk about the different Q waves here a little bit later. The first positive deflection, regardless of if there's a Q wave or not, the first positive deflection after the P wave will be the R wave. So in some cases, we may or may not have a Q wave before we have an R wave, but that first positive deflection will be that R wave. And then finally, the first negative deflection after an R wave will be the S wave. So in order to have an S wave, technically, we will have to have an R wave, all right? So again, the Q wave, the first negative deflection after the P wave. The R wave, the first positive deflection after the P wave. And the S wave will be the first negative deflection after the R wave. All right, hopefully that jogged your memory or it helped explain that a little bit more. So if we look at this complex here, we can see here's our P wave. We follow along the first negative deflection we have there. That's going to be our Q wave right here. It's followed by a positive deflection, which is the first one after the P wave, and that is our R wave. But we can see that we don't actually have a negative deflection. The complex does not go back below the isoelectric line. So in this case, we don't have an S wave. This would be a QR complex, but we still refer to it as the QRS complex. It still is ventricular depolarization, but in this case, we don't have an S wave. And so here's a very different looking QRS complex. The morphology is vastly different. We can see here, here's our P wave. If we follow along, we have this tiny little positive complex down here, and that's the first deflection. And that first deflection is positive. So in that case, that's an R wave, all right? Even though it's really small. That R wave is followed by this really large negative deflection. Any negative deflection, that first negative deflection after an R wave, is going to be an S wave. So this S wave, while it is very large, especially in comparison to the R wave, it's exactly what it is. So this QRS complex, although it looks very different, is an R wave followed by an S wave. Still represents ventricular depolarization, but it looks very different. And there can be so many different morphologies that we can see, okay? You can see the various ones. We have a QRS wave here with the predominant part of the morphology being the R wave. In this case up here, there is no Q wave. We have an R wave followed by an S wave. And we can see as we go along, there's various things. In this case, it's just a Q wave. There is no R or S wave. And all these represent different the different morphologies, okay? We just label them different based on what parts of the QRS complex are present, okay? Remember that they all represent ventricular depolarization, okay? The big question though is why? Why do we have these variety of morphologies when they're all actually representing the depolarization of the ventricles? Well, we have to remember some basic rules of electrophysiology, okay? And that the first rule that we have to always come back to is, well, how is the lead, the lead itself, and I often refer to this lead as a camera, because that's kind of how they operate with our 12 leads. How is that in relationship to the average direction of depolarization, all right? And as we go back in terms of our basics, we'll refer to as the average direction of depolarization of starting up here in our SA node and then finishing down here in the apex of that left ventricle. Well, again, if depolarization is moving primarily toward that lead or that camera, we're going to have a positive QRS complex. It's going to be upright, okay? If that depolarization is primarily moving away from that camera, then we're going to have a negative QRS complex, or primarily a negative QRS complex. And then finally, if that depolarization is moving perpendicular or at 90 degrees to that lead or that camera, then we're going to have that equiphasic or biphasic QRS complex, where it's moving, it has an upward complex as it's moving toward it, and then a negative complex as that depolarization moves past, okay? So I always have to think about that. That's going to be very determinant about how our morphology is going to look, is the relationship between the lead and the average direction of depolarization. Let's talk about an example of that. So you can see here, here's our average depolarization happening as it moves through the conduction system. Well, lead V2 sits just kind of right next to that left atrium, kind of high up on the heart itself. And when depolarization happens, you can see it initially as it moves through the atrium toward the ventricular system, it's actually moving relatively toward lead V2, okay? And so because of that, if we look at the morphology of lead V2, we have a little bit of a positive complex, in this case an R wave. So we've got an R wave because it's moving towards lead V2. And then it's going to pass lead V2, and more of the depolarization is going to actually happen past lead V2 as it's moving away. And we see that because we have primarily a negative deflection, in this case an S wave. So we have a little R wave in lead V2 followed by a large S wave. And again, that has everything to do with the relationship of where the lead sits in relation to the depolarization wave and how it looks at it. Well, lead 2 is very different than lead V2. Lead 2 is sitting down here, kind of looking upwards at the bottom part of the heart, specifically kind of looking almost directly at how depolarization follows under normal conduction, all right? Looking at that left ventricle down here. And so as depolarization happens, it's almost all primarily moving toward that camera where lead 2 sits. And we see that because we have primarily the entire complex is positive, right? It's primarily an R wave followed by just a little bit of an S wave at the end, and that really represents as the conduction gets into the Purkinje fibers, and then just at the end slightly moving away from lead 2. But that's why we have that primary positive complex or an R wave in lead 2. And then we can have the absolute opposite of lead 2, which is going to be lead AVR. Lead AVR sits above, or looks from above the right atrium, and really it's opposite of most all the other leads. So if we look at lead AVR up here, we can see that the average direction of depolarization under normal conditions completely moves away from lead AVR. So in that case, lead AVR primarily is going to have that negative deflection. It's primarily going to be an S wave up there. Okay, that's going to be its primary deflection. So again, the big thing to think about, one of the main determinants of QRS morphology is going to be the direction of depolarization as it relates to the viewpoint of the lead. All right, so with 12 different leads on our 12 lead, right, we're going to have 12 different viewpoints and 12 different QRS morphologies based on those leads. All right, again, all of them represent the depolarization of the ventricles. Now, the other factor that's going to change our morphology in each one of our leads is going to be the different pathophysiologies of the heart. So what's going wrong with our patient right now? Some of our patients obviously will have normal hearts, all right? But many of our patients, because inevitably they're sick and we're taking care of them, right, are going to have pathophysiologies that are affecting how depolarization moves through their heart. They could have conduction pathway issues like bundle branch blocks. They could be having an infarction. If they have an infarction, they're going to have dead tissue that conduction can't move through, okay? They may have hypertrophies, the hypertrophies that are going to change the morphology too, because that area of the heart is requiring a lot more depolarization to get that big, thick muscle to fire off. So there are two primary determinants of our QRS morphology is going to be the direction of depolarization, all right, in relationship to where that lead sits, and then the pathophysiologies of the patient themselves. That's what's going to determine them. All right. So looking at this here, okay, looking at our 12 lead here, we can see, right, that in each one of these different leads, we have different morphologies, especially in this case, different deflections. We've got positive deflections. We've got equiphasic or biphasic deflections. We've got negative QRS complexes. And again, these are just going to be relationship as how conduction's moving the heart in relationship to the different leads. All right. And then we can have another 12 lead here that is doing the same thing. We're getting lots of different deflections of the QRS complex. There's R waves and S waves, but they look differently because in this case, we have a conduction defect as well. This patient has a left bundle branch block. And so we're getting the mixture of both the how the leads sit in relationship to the depolarization, and then because there's a conduction path change, that changes how the depolarization moves through the heart, and that's going to affect the morphology of the morphology of the complex as well. But regardless, all of these, although they look differently, are still all QRS complexes. All right, but it just tells us is the depolarization moving towards that camera or moving away. So we can see up here in lead V1, we've got a very negative complex. It's a big S wave, all right, in lead V1. And so we know that primarily the depolarization is moving towards lead V, or moving away from lead V1. Vice versa, over here in lead 1, all right, we've primarily got a large R wave, a positive complex here. Our first deflection is positive. That's an R wave. And that tells us that the average depolarization is moving towards lead 1 as it sits in terms of relationship to the heart. Okay, so again, the QRS complex may not, even though we refer to it as the QRS complex, it may not have all three components. So it may not have a Q wave, R wave, or an S wave, or it may have a myriad of those different components, but it still all represents ventricular depolarization. What we can interpret then is which way depolarization is happening in relationship to that lead. And that's going to help us in terms of diagnosing our patient and interpreting the 12 lead. All right, friends, I would be remiss to talk about the QRS morphology without talking about the difference between the two primary Q waves. So we've got physiological Q waves, which are normal findings, normal Q waves. And then we have pathological Q waves, which pathological Q waves obviously mean that there's been a disease process. And most notably, that's representation of an infarction that's happened. All right. So typically when we see our physiological Q waves, they're a small Q wave, right? It's the first negative deflection before the R wave. And the way we usually define those is it's they're less than 1 box on the 12 lead, or less than 0.04 milliseconds. And typically what we find is that when they're less than that, when they're less than 1 box wide, they're typically not very deep either. So they're usually pretty small. And so that is how we define usually those physiologic Q waves, versus when we have a pathologic Q wave. And a pathologic Q wave is going to be once that Q wave has gotten wider than 1 box or wider than 0.04 milliseconds. And usually what we find is not only will it get wider, but it usually also gets deeper at the same time. And that what that represents is it represents depolarization actually having to move through, or actually around, an infarcted area of the heart or dead tissue. Because we know that once the heart infarcts, once there's actual dead tissue that did not get blood supply, it doesn't actually return. All right, there's no more depolarization that's going to happen through that tissue. It's dead. Okay, and so we can see the byproduct of that. The interpretation that we see on the 12 lead is that we're going to see these wide and deep Q waves that we refer to as pathologic Q waves. All right. Our physiologic Q waves, what they actually represent is depolarization across the septum of the heart. All right. So just that septum that separates the ventricles from the left and the right, just that little bit of depolarization as it moves across that's actually what is a physiologic Q wave. And thus why they're really small, like why they're not wide and they're not deep. All right. And we see them there. Versus as we think about the progress of an infarction, okay, remember that we don't just go from everything's hunky-dory to a patient having a full infarction. It's a process. And typically what we'll see is we'll start normal, the infarction happens, and that's where we get into our ST elevation. All right. And then as that infarction goes through, and if nothing's done about it and that tissue starts to die, that small Q wave develops into a bigger Q wave. That ST elevation will start to decrease. And what we're left with is that pathological Q wave where that infarction took place. All right. And oftentimes what we'll see on the 12 lead itself, the interpretation of the 12 lead, is it'll actually say age undetermined infarction. And that's what the 12 lead, what the machine is actually interpreting is it's saying, I see a pathological Q wave on there. There's a Q wave that's wider than 1 box, the computer knows that it represents an old infarction. It just doesn't know when it happened. So it doesn't know if that infarction took place 4 hours ago or if that infarction took place 4 days ago. Okay, and we can see even on this little snippet of a 12 lead, we can see in the inferior leads here, we have these large, wide Q waves in the inferior, in 2, 3, and AVF, representing an inferior infarction that is more or less completely run its course. Sometimes cardiologists will refer to as patients being Q'd out, meaning that there's Q waves, these large Q waves throughout the area of the infarction. And what that means is that that part of the heart is already fully infarcted, and that really intervention at that point in time is not going to be of much use at that point. All right, these patients are going to be managed medically, typically. All right. So here is another 12 lead. We can see on here that we've got a large inferior infarction, but if we look for evidence of Q waves, there's no Q waves there. All right, we've just got R waves followed by these large tombstone ST elevation patterns. This patient is actively infarcting right now, okay? Versus this patient here, also an inferior infarction, but we can see evidence of these large Q waves. Again, this patient's infarction has pretty much come to an end. That area of the heart is going to be dead, right? So in this case, we're going to have these large pathological Q waves rather than our physiological Q waves that we would normally see. All right, hopefully that was helpful. All right, so that is the QRS complex. Hopefully that's been really informative for you, or a good review of one of the different components of the QRS, of being able to interpret that a little bit, and more so to be able to help diagnose your patient, help interpret that 12 lead a little bit better, because you now have a better understanding of why those different deflections are what they are. Okay, thanks for joining us. As always, this is Pulse Education. If this was helpful, please like this video, We would love for you to subscribe, tell other people about it, about Pulse Education, and we'll look forward to seeing you guys next week. Bye.